You can have reflux that is so extensive that the child actually loses weight. What impedance has provided us is it has provided us the opportunity to understand that 60% of reflux is non-acid reflux. Reflux is not an acid disease. It's a motility disorder.
Many people think that pain is acid reflux, painless is non-acid reflux.
I have several parents that actually overfeed their children. And they tell me that this is cultural, that they want a fat baby. Thickened formula actually does work. And that thickening effect actually lasts for at least 120 to perhaps 150 minutes, which represents the half-life of emptying of that stomach.
Try it first. Try the Pax one first.
You may want to try it first. Try the best evidence-based AR formula on the market.
Do you think which one would be more disastrous? The DIY thickener by the husband or by the grandmother? Dear all, Ramadan Kareem, welcome to Nova Talks Pediatrics Expert Voice. Spit up is a daily reality for thriving infants, and in most cases, it's just normal reflux. Today, we'll cut through the worry. What's normal, when to take a closer look, and what actually works. Our goal? To help you give families clear, confident advice in just one visit. I am Dr. Yasser Negm, consultant pediatrician and pediatric gastroenterologist, and we are delighted to welcome Dr. Carmelo Cuffari, Associate Professor of Pediatrics at the George Washington University School of Medicine in Washington, D.C. Thank you for joining us today.
The pleasure is mine, Dr. Yasser, and thank you very much for that gracious introduction.
What is the difference between gastroesophageal reflux and gastroesophageal reflux disease?
Gastroesophageal reflux, the acronym GER, is essentially a natural physiological process. It involves the expulsion, if you will, of gastric contents from the stomach through the food pipe and out from the mouth. It can vary anywhere between a little spit up to a substantial amount. It occurs in up to 70 to 90% of individuals. It's part of the natural process. There are anatomical and functional issues that the infant has to overcome. GERD, or gastroesophageal reflux disease, means that something is beyond the normal physiological process. Although most children will grow out of it, certainly by 9 to 12 months of age, there are some children, even about 25% of the patients that I see in my clinic, that actually have reflux disease as defined as significant pain with reflux, respiratory embarrassment, anywhere between apneic episodes to choking, turning blue, aspirational episodes. You can have reflux that is so extensive that the child actually loses weight. The distinction, of course, is to separate reflux from vomiting. Where reflux is effortless, vomiting is forceful.
What trajectory should the clinician expect over the course of the first year of life?
Whether you're dealing with gastroesophageal reflux or GERD, gastroesophageal reflux disease, most children will actually overcome it. Generally, the symptoms will start within the very first week of life. As that maturational process improves, as the clearance improves, generally those symptoms will actually peak by 7, improve by 9 to 12 months, and generally disappear by 12 to 15 months.
Interesting. What is the difference between acid and non-acid, and does that have any impact on the management?
That's an extremely important question, Dr. Yasser, in many respects. What impedance has provided us is it has provided us the opportunity to understand that 60% of reflux is non-acid reflux. Reflux in general, either due to poor clearance or inadequate compliance of the esophagus to reflux in a child, causes pain in some children and does not necessarily cause erosive esophagitis. In that respect, the understanding that we are not dealing with predominantly an acid disease, which occurs in 60% of individuals where the reflux is non-acid, it sort of touches upon the value of PPI therapy. in essence, there's really very little role for acid suppression therapy, PPI, in a child with reflux, physiological reflux, or even for reflux disease without erosive esophagitis. So it's important to understand, reflux is not an acid disease. It's a motility disorder. Majority of the children have non-acid reflux. There is very little role for acid suppression in these children.
Even if they are having pain. Many people think that pain is acid reflux, painless is non-acid reflux.
In a purest sense, the only real evidence base is the value of acid suppression, PPI therapy in children with erosive esophagitis. Now, in all honesty, do I use acid suppression? Of course I use acid suppression. I don't do endoscopies on all of my patients. But if we look at the European Society of Pediatric Gastroenterology, as well as the North American Society of Pediatric Gastroenterology, they do suggest empiric acid suppression therapy. A 2-week course of acid suppression is not necessarily an unusual endeavor that gastroenterologists and even pediatricians will endeavor upon to try to obviate some of the child's symptoms. But we have to be sensitive that it is not one of the primary therapies to manage reflux and reflux disease, mainly because it essentially doesn't work. Essentially, by virtue of the fact that we're not dealing with acid reflux in 60% of the patients, and we're not dealing with erosive esophagitis. But even more importantly, we have to underscore the potential risk factors with long-term PPI use. They potentially can cause long-term issues, including susceptibility to opportunistic infections, certain upper respiratory and gastroenterological infections. In long-term use, they can also be associated with bone demilitarization. And if we're following Aspagan, NASPGHAN guidelines, it should be at the lower end of the treatment algorithm.
This is an awesome comprehensive answer. Thank you for that. This question is in the minds of many of our audience. 3 or 4 important points in the history taking which they should pay attention to and would make a difference in their management plan.
I have several parents that actually overfeed their children, and they tell me that this is cultural, that they want a fat baby. So understanding exactly how much volume and how frequently that child is being fed, especially if they're on a formula, is extremely important, because overfeeding is not good. It overwhelms that child's capacity to tolerate that volume in an immature system. Moreover, it's also important to understand whether they're using adequate practices. Burping in the middle of the feeds and obviously at the end of the feeds is extremely important in order to minimize the amount of air intake. Children who are on bottle feeding, making sure that not too much air is actually being sucked by the child during the actual feeding process. The positioning of that child, also the rapport that child has with the mom and the mom with the child. What kind of measures are they taking in terms of positioning the child after the child is being fed? During the daytime, it's not unusual also to have the children maintain, especially with reflux, maintain somewhat of an elevated position. But in the evening, I think it's extremely important to lay the child flat on their back, not on their fronts, in order to minimize the risk of sudden infant death syndrome. So taking all this information in is extremely important. The history is integral in allowing us to provide that reassurance, that educational process that is so necessary to allow that mom to leave confident that we are all doing the best in managing their child's needs.
So we have a variety of thickeners, mainly starch, locust bean gum, which is carob in lay terms, and pectin. What is the difference between these 3 pros and cons of each?
On an evidence-based basis, especially among parents that are bottle feeding their children, thickened formula actually does work. Now, there's a variety of thickeners, and they work by different mechanisms, and several meta-analyses have been done, and they all work to some greater or lesser extent, but they all have some issues that really separate them. We often use starch thickeners, rice thickeners, These two cereals are associated with increased gastric emptying, which can actually have a prokinetic effect. Whether they increase the thickness enough so that it improves the viscosity of the formula to manage reflux, aside from the science behind it, clinical studies would suggest that they do indeed work. When we think about soluble and insoluble fiber, they definitely do have a thickening effect. And these studies have been done at various pHs within the stomach to really assess the viscosity of these respective sectors. The problem with a lot of these soluble and insoluble fibers, the soluble fiber meaning the locust bean gum and the insoluble fiber being the carob, is that it not only improves the viscosity, if you will, and to some extent delays gastric emptying, but it also provides an increased load to the lower intestinal symptoms that can also be associated with alteration in bowel movements. It can accelerate the bowel movements. It can allow for diarrheal symptoms, bloating, increased flatulence that can actually make things worse. So when we're prescribing thickeners, we have to look at the tolerance aspect, but we also have to look at how well they clinically improve the child's reflux symptoms. But certainly before we even remotely consider the notion of hypoallergenic formulas or even acid suppression or even referring to a gastroenterologist for further investigations, the Aspigen and Aspigen definitely does suggest the use of AR formulas.
There is no question we should continue breastfeeding as much as we can. But we found out that some companies now go for what we call the Pax complex. So starch with locust bean, with pectin, all together. Is that going to make the anti-reflux effect more efficient? What is the art behind that?
Obviously, the inventors of the Pax complex were ingenious enough to choose the right amount of starch, the right amount of locust bean, which is far less in the Pax complex compared to some of the AR formulas. But not only starch and locust bean, but also the combination with pectin. And the pectin is extremely important. The innovation in the development of the Pax complex really comes down to some very good science, where they looked at the viscosity of the Pax complex in relation to simple measures of viscosity at different gastric pHs. And the pectin component is front and center in allowing improved viscosity of the formula, especially in the context of near normal pHs. And why is that important? It's important because near normal gastric pH is essentially the hallmark of the gastric pH in the child after that child is being fed. We also alluded to the fact that 60% of children have non-acid reflux. So the fact that you have such an enhanced viscosity induced by the pectin at neutral pH, which is not seen among the locust bean nor in the starch, and this is based on very good studies, suggests a tremendous thickening effect, if you will, of the pectin by itself. And that thickening effect actually lasts for at least 120 to perhaps 150 minutes, which represents the half-life of emptying of that stomach. That child's stomach should be virtually empty by 120 to 150 minutes. Then thereafter, the locust bean component of the Pax complex and the starch actually allows, if you will, for that viscosity to improve in more acidic pHs. So if you see the enhanced induction of viscosity in these Pax enhanced formulas, and this is based on good, sound scientific measures of viscosity, you can theoretically, if you will, suggest that this ingenious combination would theoretically have the best viscosity effect in order to manage gastroesophageal reflux. So obviously we have to mother the science with the clinical data, and indeed the great Christophe Dupont as well as Dr. Van den Plas have done a very good study, the so-called SONAR study, that actually used the PAX complex to evaluate for gastroesophageal reflux, but also some element of gastroesophageal reflux disease. They found that not only did the majority of the children, well over 80 to 85% of the children, have a positive effect in terms of a decrease in reflux frequency, but they also had a significant decrease in reflux volume. As early as 3 days into the use of the PAX complex enhanced formula, an effect that was sustained in following these children after several weeks, up to 3 months. The study by Dr. DuPont showed very nicely that these children also had improved stool frequency and consistency. They no longer had diarrheal stools. They no longer had constipated stool. They had improved regulation of their stools, which is probably a function, if you will, of the pectin component, the prebiotic component within the PAX complex, that in my opinion probably enhances the microbiome, provides a preferential fuel for the bacteria for long short-chain fatty acids, which enhances the vitality of the colonocytes and thus the motility of the actual colon itself. I also want to stress one important thing, Dr. Yasser. Half of the patients that they recruited for that study had previously, quote unquote, failed traditional AR formulas. And those patients were actually salvaged with the PAX complex. In fact, those children with reflux disease that were, quote unquote, failure to thrive actually were able to gain weight after 3 months of follow-up. So in essence, if the child is spitting less, they're happier, their quality of life is improved, the sanity of the parents improve, and I would also suggest the sanity of the physicians are improved as well, but they are also able to grow and gain weight. So I would even suggest that even in the treatment algorithm put forward by the NASPGHAN and the ASPGHAN, we could make an argument, if you're on a traditional AR formula.
Try it first. Try the PAX one first.
You may want to try it first. Try the best evidence-based AR formula on the market. But if you choose not to use the PAX complex and you want to choose a traditional AR formula based on starch, based on carob, based on locust bean, based on rice, and that child fails, consider the PAX complex enhanced formula as a salvage therapy.
I'll tell you about a possible real-life scenario in some cultures. Okay, you've got this mother coming from the doctor's office and want to start this AR formula, whether with PAX or without PAX, and her mother, the grandmother, would give her some advice. No, just leave this alone. And I used to put starch or rice in the milk, okay, and give it to the baby, and it was wonderful. And then the husband would interfere and I would make it better and so on. And we've got this mother following her mom's or her husband's DIY thickening. What do you think of this?
Well, it's interesting that you mentioned that, Dr. Yasser. Just last week in clinic, I had a mom who was thickening her formula with 1 teaspoon of starch cereal for every couple ounces of formula, which is perhaps the most placebo effect that you could ever possibly imagine because it certainly had no effect. When we think about 1 tablespoon equal to 3 teaspoons, we were not achieving any of that increased viscosity that we would actually aspire to with the thickened formula. The value of an AR formula is that all the heavy lifting has been done in order to come up with the amount of cereal in the right combination, especially when we're dealing with the PAX complex, with the right amount of water in order to rehydrate that formula that achieves the best, if you will, anti-reflux effect.
Do you think which one would be more disastrous? The DIY thickener by the husband or by the grandmother?
I think that's a politically charged question, Dr. Yasser, and I've gotten in trouble answering in either directions. So I'll leave it up to you to answer.
How do you see the future of management of reflux or reflux disease? How do you see AI incorporated into the management of reflux?
Well, personalized care, I think, is front and center as trying to establish an improved dialogue with our parents is extremely important. Our electronic patient systems are very instructive in allowing for that back and forth communication. And I always suggest to the parents, if you have any concerns, do not feel embarrassed or concerned to even to reach out to us. I give them all this information. I expect them to at least register in their minds, if not on paper, all the potential points that would make me very concerned for further investigations or further treatment along the treatment algorithm that we described. In many respects, AI is the way of the future. It's going to integrate a lot of this information. It's also going to integrate investigative procedures. All this data, if you will be at our fingertips. And the parents will be accessible to all this data, which not only will allow us to improve our diagnosis, improve our clinical follow-up, maintain a high level of sensitivity to other potential complications that would make us think of something outside of just general reflux, and at the end, hopefully improve patient care and decrease the risk of complications, not only of our therapy, but also of mismanagement.
Dr. Cuffari, many thanks for the wealth of knowledge and experience you provided today.
The pleasure was mine, Dr. Yasser. Thank you very much.
A wrap-up. Most infant regurgitation is physiologic and improves with time. Start with feeding optimization. Consider thickening with a defined trial window and reserve testing medications for specific indication. Ramadan Kareem, enjoy the rest of the holy month and wait for our next episode of Nova Talks.